The algorithm for deciding what to do for a newly diagnosed kidney cancer patient is first, do they need therapy at that time? Even if they have stage 4 disease, there are many patients with slowly growing disease at small volume that don't need to start therapy and can be observed. The second question I ask is, are they a candidate for immunotherapy or not? And while most patients are a candidate for immune therapy, not everybody is, because they may have autoimmune conditions that could be life-threatening if they were exacerbated by immunotherapy, and they could be on immunosuppressive drugs that will negate the effect of immune therapy. But assuming they are a candidate for immune therapy, then my approach is to give them a pure immune therapy for everybody where I can get approval for it.
It's really changed the prognosis and the outlook tremendously since the early days, and I think that many patients are enjoying prolonged survival with these medications. I think we're now seeing some durable responses with this, and I do think that some patients are being cured of their metastatic kidney cancer with some of the current combinations.
There's two major classes of drugs that are approved at this point in time that we use most frequently. The first are immune modulating therapies, and these are the so-called checkpoint therapies. These are drugs that basically help the immune system work better against the cancer. If you do have immune cells called T cells that probably recognize the cancer, but they're being thwarted by the cancer, and by using these drugs you can minimize that thwarting. The second class of drugs are blood vessel starving or targeted drugs. And the way these drugs work and how they work is that kidney tumor, especially clear cell kidney cancer, it's secreting factors because it's thinking erroneously that it's missing oxygen, and it's creating all kinds of factors to increase blood vessels. And so these are essentially blood vessel starving therapies. They block receptors on the blood vessels and a couple of other receptors, and they decrease blood vessel growth, and probably more importantly, remodel blood vessels in a way that allows the immune therapy to work better.
There are different factors that go into determining first-line treatment for patients with RCC. One is really the bulk or the degree of tumor that's metastasized. Another is really the pace at which the tumor seems to be progressing, and also comorbidities that the patient has that is important in tailoring treatment, as well as really the patient's interest and preference in terms of therapy and timing of therapy and choice of medication. So my approach really is to discuss various options and then make recommendations, but certainly the choice of the program and whether or not the first-line therapy will be given is the patient's choice.
When I started being involved in the kidney cancer field, the median survival was somewhere around 10 months. Then we were now seeing about 10% of patients who we believed are cured. We still have a ways to go, but I think a good percentage of those 50% of patients who are alive at 5 years, perhaps a total of 30 to 40% of the patients who started at baseline are probably cured and can come off therapy and get back to their normal lives. And so that's an amazing advance, and it's turned the kidney cancer from a disease that was virtually always fatal to a disease where we have a lot of patients who are getting a second chance at life and getting a chance to go back and witness various important milestones in their family life, contribute to their workplace, and also to enjoy things on their bucket list that they might have never had a chance to do.